Hello everyone, my name is Joseph Nassar, Research Fellow in Orthopaedic Surgery at Brown University. Today, I will be going over our study titled A Blinded Analysis of Quality and Fidelity in Orthopedic Patient Education Materials Simplified by ChatGPT and Humans, published in the JBJS. And I want to share a bit about why we did this research and what we found. It really all starts in the clinic. We hand patients education materials every single day, before surgery, after surgery, for their rehab, and we assume they go home, read them, and understand them. But the truth is, most of these materials are written at roughly a 9th grade reading level. National guidelines recommend a 6th grade. And when you consider that nearly half of American adults read below that 6th grade reading level, you realize we may have a much bigger communication problem than we acknowledge. Our group had already documented this gap across 806 orthopedic materials in EPIC's Elsevier library, in both English and Spanish languages. So the natural next question was whether we could fix it, and specifically whether AI could fix it at scale in a way that is actually safe. What surprised us, and I will be honest, it genuinely surprised us, was how well ChatGPT performed on Fidelity. We expected it to simplify the language. What we did not expect was that in English, ChatGPT 4.0 actually produced fewer omissions and fewer inconsistencies than the human simplified versions that Elsevier had already developed. That was a meaningful finding. Spanish told a different story. ChatGPT 4.0 introduced significantly more hallucinations in Spanish than the human versions did, which is a real safety concern for any non-English speaking patient. But here is what made the finding even more interesting. When we ran the same analysis with ChatGPT 5, the hallucination rate in Spanish dropped substantially to levels that are comparable to the human versions in just one model generation. That kind of improvement is remarkable, and it tells us that the technology is advancing faster than most people realize. Now, one honest obstacle we ran into is that even after AI simplification, more than half of the English materials still exceeded the 6th grade threshold. Some medical terminology simply cannot be swapped for simpler words without losing clinical accuracy. Readability has a ceiling when the content itself is complex, and that is important to acknowledge. It also reflects a broader limitation of readability scores themselves. These formulas measure linguistic complexity, things like word length and sentence structure, but they do not measure whether a patient actually understood what they read. A document can score well on a readability formula and still be confusing, and the gap between measured readability and real comprehension is something our field still needs to address. What does this mean for practice? I would say that AI simplified patient education materials are not ready to go out the door unsupervised, but they are ready to be a starting point, a draft that a physician or clinical staff member reviews and approves before it reaches the patient. That workflow is realistic, it is scalable, and based on our data, it can meaningfully improve how we communicate with patients across languages. The work is not done, but I think we are genuinely closer to giving every patient, regardless of their reading level or their language, materials they can actually understand and use. Thank you.